I'd like to now introduce to you Dr. Gregory Diette. He is the Professor of Medicine, Epidemiology, and Environmental Health Sciences at the Johns Hopkins University. He's a pulmonologist with a practice devoted to the care of patients with obstructive lung diseases, including asthma and COPD. Dr. Diette has an extensive portfolio of patient-based research in asthma and COPD supported by NIH and other sponsors. His current research focuses on identifying environmental causes of obstructive lung diseases, the role of diet in the development of asthma, as well as understanding and reducing disparities in health of racial and ethnic minorities. Thank you so much for coming in. We look forward to it.
Thanks very much, everybody, for coming for listening to this. So I'm going to talk more about another disease topic. Our center, also the Johns Hopkins one, is one of the 15-year centers, and Peyton Eggleston is one of my colleagues, retired. I'm now the program director, but we're very grateful for the funding. This is just a figure that shows what it looks like over time. We started in 1998, and we've had 3 Children's Center awards with also some additional funding from other agencies as well to support this. So this has been a long-time effort for us. Just so you know, in terms of the disease that we deal with, this is asthma, and most people either have it or know somebody who has it or has some personal experience, but just so you know, it's something that's caused by the environment, it's aggravated by the environment, and the thing that you need to know here is if you look at the figure, you look at the lower right, that's what you're trying to breathe through instead of the one that's a little bit to its left. It's a narrow airway that's constricted because the muscle's tight, also because there's fluid and cells and things, and so it's a very difficult disease for people because you're trying to breathe through these tubes that just won't open up properly. This is a time scale that starts in 1980. The increase in this probably started a little before 1980, but it's been relentless. It's been steady every year that we have more and more of it, and in children in particular, we now have more than 10% of our kids that have asthma as an active condition. If you want to understand what we're up to, I think this slide, this is a boy who's in our study. He's somebody's patient also, and I'll mention I'm a medical doctor as well, and I take care of asthmatics. And this is a typical issue for us, is that we have people just like him. So he's African American. He lives in East Baltimore, which is the area near our hospital. He comes from a household with low income. He's very symptomatic. So in 2 weeks, he's had 4 days out of those where he's having active symptoms. He's woken up twice at night, which we know is associated with missing school in many cases. He's had 4 unscheduled doctor visits because of his asthma, and he's on really every medication known to help asthma. Despite that, he has all of these problems. And his house has an active smoker. It has mice and it has cockroaches. And these are some of the things that we worry about. So I think that the main way to describe what our center is after is trying to figure out why does he have asthma and why is it so bad? Why does a boy like him get it in the first place, and how come it's bothering him so much? And our focus has been on the indoor environment especially, lifestyle, now especially diet, and then susceptibility factors, so race, poverty, neighborhood, genes, and other things. What's this whole milieu that makes this asthma come up newly, and what keeps it there? We know about irritants. Irritants bother lots of things, but including asthma, they irritate the airways, and this is one of our main foci, if you will. Secondhand tobacco smoke being a big one for kids, and then other pollutants. We've heard about particulate matter, and then gases like ozone and nitrogen dioxide, all important. The allergens that we think about are outdoors and indoors, so the pollens that we're all familiar with, trees, grasses, and weeds that bloom different times of the year, dust mites which live in our beds, furry pets, and then pests, cockroaches and mice. And I'll tell you a little bit about the mice especially before we're done. So I mentioned indoor. Indoor air is our focus, so why am I showing you this picture? A couple of reasons. One is this is a very recent picture from China, and this shows China during the day with a policeman with his hands up like this, and it's 500 micrograms per meter cubed, which doesn't mean something to everybody, but that's a very high concentration, and you'll see other slides that you'll be able to relate this to. The reason I got this picture from China is a couple-fold, but one is because luckily we don't have pictures like this. I couldn't take this picture in Washington, D.C., and the reason that I can't is because the way that pollution is distributed in the world is not accidental, right? But it is this way. Where you see this figure, this shows particulate matter, and where red is the worst or the highest particulate matter, blue is the least. And what you can see is on the east coast of the United States, we're kind of in the yellow, light blue. Not bad, but not great. But where you look at China, all the way over to the right there, what you'll see is that's the darkest of the red, among the worst pollution in the world, along with other developing countries. The reason I say it's not an accident is because we have a Clean Air Act, and in 1970 we you see that arrow, you see particulate matter take a dramatic shift downwards, and it's been moving downwards ever since. I put that out there for you for two reasons. One is it's probably one of the most important laws for health in the United States ever, but also that's actually not what I'm talking about. So this is outdoor air, which matters a ton. It also comes inside our houses, which matters a ton. But what we're looking at is what's actually inside the houses. So this is our laboratory. Our laboratory is a neighborhood like this, which is East Baltimore. It's turn of the previous century houses for the most part, so decades old or maybe 100 years old. And what we're worried about is what's going on inside these homes that might be making asthma come along. So this is from one of our first studies in the first iteration of the Children's Center, and this shows a figure from one particular home. And what's important about this is where you look at the red line, that's the measurement of particulate matter in about a 24-hour period. So that scales on the minutes and hours scales. This is one particular period, and what you can see is this zigzagging red line, which shows what it is indoors. We live in Baltimore, not thought of as like sort of the cleanest outdoor air in the country. You know, if you think of Baltimore, it's an urban center. But what we measured simultaneously is those lines that are down near the bottom, the blue and the green, show what outdoor air was simultaneously. So a remarkably different experience inside than outside. And the reason I put that purple line there is that's the level, that's the 500 microgram level that you saw with the policeman in China holding up his hands. So that's the bar that would represent 500 micrograms. So we see excursions that are even higher than what we would have seen in that picture in China inside the home. One of our first observations with this, it doesn't look like much, but it's a figure that shows what's the difference between indoor air on average in our homes in Baltimore City compared to outside. It's called a box and whisker plot, and so the median or the midpoint value is that horizontal dark bar. The left-hand part being indoor pollution, outside being the squatter one that's down like this. And what you can see is that red line is what the EPA at the time regulated for outdoor air. There's no such thing as an EPA-regulated indoor, in-home air limit. But if there were, 3/4 of our homes would have flunked that standard, whereas more than 3/4 of our days in Baltimore would not have flunked that standard. So we're really looking at an indoor problem that's really disproportionate to what we see outside. This is from a Baltimore Sun article they did about some of our work for kids with asthma. The air that they breathe at home can be worse than the pollution and pollen outdoors. This was startling for us because, you sort of think about, you go inside, you hear about there's a bad air day, go inside. Well, where are you going? This is the issue. You're inside the house. Our work and others, this comes from our work, this shows symptoms of asthma that are related to very small increments. So remember, the policeman's holding his hands up in 500 microgram air. This is for every 10, you see a several % increase in asthma symptoms for kids living in our homes. So for every 10 of those increments of particles. So we're able to show that this matters, and it's the indoor measured particulate matter. Also through the work supported by the center, we've been able to find out what some of the causes are, smoking being the big one. It's double inside a smoking house what it is in a non-smoking house. Every cigarette puts one of those units of micrograms per meter cubed into the air. So a 20 cigarettes a day, a pack is 20 micrograms in the air. Sweeping does it, and stove does too. And stove's very important because it's a burning source, and we all know about this international problem of cook stoves. We've got a local domestic problem with cook stoves too. Cook stoves can put particles in the air, and they can also put a gas in the air, which is NO2. And in Baltimore City, what we have is gas-burning stoves for the most part. It's not electric stoves by and large, and for the most part, they're sitting in the middle of the room and they're not vented to the outside, so all the fumes from the cooking actually go up into the living space. Some people have a vent too. Some of you may have this experience where you have one of these ones that sort of blows in your face. That doesn't help either, by the way, just because you turn it on. It's not helpful. But we do know that this occurs, that a gas stove is a source of it. We also know that NO2, when the concentration's higher, asthma's worse in these kids, no matter what the particulate matter level is. So the NO2 functions independently of the particles. That's important for a slide I'll show you in a couple minutes, because this is a gas, not a particle. So one of the studies that was supported in our first round of the Children's Centers too was looking at tackling two things. I'm not going to show you the cockroach data, but it tried to reduce cockroaches, which it did, and then also tried to reduce particulate matter only using a HEPA-containing air cleaner. This was an off-the-shelf commercially available air cleaner, and what you can see is in the top two bars are different components of particulate matter in the control group. Went up a teeny bit, but more or less horizontal, but there's between a 34 and a 40% drop on the scale of 6 months to 12 months. So it's sustainable by turning on an air cleaner and dropping this amount of particulate matter. This is a picture from one of the homes. I like this picture an awful lot. One is it shows how simple it is to plug it in. It also shows that we're not naive enough to think that this is the entire solution to the problem, right? There's a lot more going on in a house than just a need for an air cleaner, but there it is, and it's that one happened to be on when we visited. But these things do work. And what this slide shows is in that same time scale, over 12 months, the lower bar is the good one. That's the percentage decrease in days with asthma symptoms. And you can see a symptom difference in kids who are using an air cleaner compared to those who don't. So this for us has become like a really exciting thing. Even though I'm not showing you a lot of basic science today, we're trying to understand mechanisms. We really like these simple solutions, these things that you can implement right away that work. And that's a driving factor for us. Another study that we did is the so-called PREACH study. This was funded in the second round, and this was tackling a related question, but what happens with those smokers? This focused on homes with a smoker, and we tried to see, could we get them to quit smoking? Could we get them to encourage smoking elsewhere? That's the health coach thing you see. And then we did it, an air cleaner with and without that health coach. We thought the behavioral thing might help. I can tell you up front the behavioral thing wasn't worth anything. Nothing. Zero, right? Okay, so everybody continued to smoke. Everybody still smoked in the house. Everybody, everything was the same. But what the findings that I'll show you here that matter for us is, this is just an image too. This is what you're trying to avoid, right? This is actually this is from the UK. This is one of their public service announcements, but I love it. It's a baby in a car seat. I like it because they think enough to put the baby in the car seat, but you still smoke inside the car. Same thing in the house. It's the same experience living in a house where there's a smoker. And what the PREACH study showed was that particulate matter went up a few points in the control group. It went down 18 points in the HEPA filter group, whether you had a health coach or not. And what we saw was a symptom day reduction that translated to about 33 days a year, which if you imagine, it's more than a month's worth of days that a kid who had an air cleaner would not have asthma symptoms compared to whether they would. So it's not a trivial effect. This is the kind of effect you see with some of the more potent medications that are on the market for asthma. I'm showing you one commercial slide. I don't have any interest in them. This is one company that makes an air cleaner, and the reason they're relevant for us was that I was talking about particles, and those prior studies had HEPA-containing air filters that strain out the fine particles. They don't do anything for gases, though. So for NO2, we couldn't really think to reduce it, and so we were talking with these guys at this particular company and said, we've seen you have a HEPA-containing device. Is there anything you can help us with? And they said, sure, give us a chance to make something up, and they put 20 pounds of an activated carbon fiber inside there that they said this ought to adsorb or sort of collect these gases. So we said that sounds pretty good. We want to try that out also in one of our studies. And we got funding from HUD because one of the things about asthma is that the guidelines won't embrace a new something new until you've proven that it works at all. And then eventually we have to do a study about health. But we did this randomized control trial of going into homes with gas stoves and said we're either going to replace your stove with an electric one, get rid of the source, or put in air purifiers, 2 of them in this case, or put in a hood with a professional who installs a hood and vents the gases outside. And just the short story here is that the hood didn't work, but the air purifier is the middle bar, and then the stove replacement is the bottom one, the most favorable. Those 2 both work, and they both work for an important amount. That's already a known important amount of reduction of NO2. So we kind of liked it because you get rid of the source of the NO2, that's great, but if you don't do that, you could plug in an air cleaner, and that might help as well. Last thing in terms of some of these findings, so this is actually sort of from a community service poster that our community advisory board helped us make about some of the things we'd found. That's a mouse and it's mouse poop, sitting there next to it. The issue isn't mouse poop, by the way, it's mouse urine. And so there's a protein in urine. It's disgusting, right? I mean, it's absolutely disgusting. It's in 100% of our houses in Baltimore, of the ones that we've studied, 100%. It's airborne in 84% of them, and it's a protein. It's a pheromone binding protein. So I guess if when mice want to attract a mate, they pee on the floor. The mate comes running and there you go. So anyway, but it's everywhere, and it turns out that it's very harmful, and it's very harmful in particular. What this figure shows is in the red figure are kids who have a skin test positive to mouse, so they make an allergic response to mouse. The other one is kids who don't have that response, and what you see is the more and more bedroom mouse allergen they have, the greater likelihood they are of having an acute healthcare visit. That means emergency room visit, things like that. And the scale there is well, the red is from 20 up to almost 80%. So we're seeing most of our hospitalizations are actually in that skin test positive, highly exposed group for mice. Really important. And the center helped us find that, and then we're able to leverage center findings into other funding. So in this case from NIAID, and our colleague Elizabeth Matsui is running a trial now to see, can you reduce mouse sufficiently that it'll improve asthma symptoms? So it's kind of the way our center goes, is it goes from sort of figuring out what it is that's bothering the asthma to then trying to find a solution, either directly with the funding or with another partner. Last thing I want to mention, just to finish up where we are now, that same boy that I mentioned, the one who's having so many symptoms, this also is what he was eating around the time that we met him. And I think it's important for a lot of reasons. One is because I'm not casting any judgment. I think my kids eat this regularly, and except for the greens, the string beans. Everything else here is on their menu. So it's sugary cereal and milk, cheese sandwich, hot dog, pancakes, butter, bacon, a lot of sugary drinks, potato chips, and so forth. And so this is a typical diet in a lot of ways for kids, and for this boy in particular, this was his diet. The reason it matters is because if you look, let me see if I got right here, that arrow is pointing to a curve. That metal curve is showing obesity over time in the United States, and obesity, it didn't just sort of creep up. There's an inflection point where right around the same time that asthma started to become very, very common, obesity started to become very, very common, and those trajectories are parallel to each other. And so it's logical to think that either obesity causes asthma or there's some underlying factor that could cause both. And we had massive dietary changes in what we eat over the same time period. So that's become a very important focus for our center is there somehow that this diet that this boy is eating, could that somehow make a difference? One study that one of our colleagues did was done in Baltimore in African Americans and looked at what the diet was in the neighborhood where we're doing our studies, and found out that the average fruit servings was about 2, a little less than the USDA recommended at the time. The average veg serving about 0.7 servings per day, so not so much. Meat servings 8. There's no decimal missing them. 8 servings of meat a day, which is unbelievable. 2/3 of them had no fruit, 3/4 had no vegetables, and the big 2 contributors to energy were chicken, mostly fried chicken, and then also soda. So you can imagine what this diet is. What's important about it is that there's good evidence that this sort of diet, particularly meat fats of certain sorts, may promote inflammation, not just important for asthma, but also for heart disease and other things. And so we've looked at the diet as both being sort of pro-inflammatory, pushing that inflammation, but by not getting fruits and veg and other things, also lacking the antioxidant capacity that you need to protect yourself. So our current iteration of the center is focused on this, which we called it Asthma Diet, and we've got a suite of projects that are some basic science projects and some human projects. We're measuring the kids, what they're exposed to, we're measuring what they're eating, and our idea is that we'll be able to show that they're susceptible to the pollution and the allergens more so when their diet is skewed towards that high-fat American-style diet. We have clinical trials where we're testing the idea that a Mediterranean-style diet that's highly characterized can actually interrupt the inflammation. And then we have mouse models where we can manipulate the diet exquisitely well for mice and manipulate their fatty acids, so the so-called omega-3s or omega-6s. We can give them different ratios of that and then see how they respond to allergens and pollutants. Pollutants, by the way, collected by Pat Bricey. The pollutants that we use in our animal models are collected directly from the home. So this isn't some sort of lab specimen. This is stuff that we suction out of the air and see how the mice respond. So that's the basic concept that the diet modifies the response to the allergens and pollutants. I'm going to finish here with acknowledgments. First of all, for our funders, it's importantly EPA and NIEHS, and they actually this is the nidus for so much of our work. So our center does a lot of stuff, but so many things bud off of it that they're not our only sponsors, but it's the core. It's how we organize ourselves. The reason there's a list of people here too is that it's not me alone, and not even nearly so. We have about 50 or so people between investigators and staff that are currently working on the project. So it's a fairly big program, and a lot of people to thank. So thank you very much.
Do you have any questions for Greg before I say my thanks to one and all? Anybody? So again, for me, go ahead. Yes, go ahead.
I didn't know that patient was resulting in such a large increase.
I don't think the vent hoods just didn't work. I think one of the problems is you have to use them, which is true of all kinds of things. So, and I don't think people used them much. I think it's a coincidence that it went up. I think we just measured at a time when there was more cooking, but I don't think they make there be more NO2. But they didn't work is the bottom line.
Was there another question? Yes.
I was interested in the picture of the housing that you showed. Baltimore and Washington are very similar that way. It looked like there were a lot of row houses and very dense housing. With regard to some of the work that you're trying to do about reducing pests, it seems like in that kind of housing stock, even if the family of the affected child is keeping an immaculate house, if the neighbors in the adjoining houses or apartments have mice and cockroaches and things, you're going to have them too. Has your work or any of the other studies that you're aware of looked at sort of more neighborhood-based or block-based intervention?
Well, I think so. It's a great question. Just in case people didn't hear it, the issue is like with row houses. Can you really sort of modify your own row house and make it not have pests? But the answer very clearly has been shown. Yes, you can, and not by us, but by other investigators. Including NIEHS investigators. And Ricky too. I'm sorry. Yeah, there are plenty. And I think the notion is that cockroaches and mice and other things are lazy, right? I mean they're not going to go out of their way to get food and water. So if the next door house is the one that's got the food sitting around in the water, guess what? That's where they go. And so that's really been what's been shown. Also, simple things like plugging up holes. The mice need to find a way into the house, so plugging up holes does work. So you can definitely make your row house less attractive than the ones on either side.
So,
I have a sort of a meta level question. Both you, Brenda, and Ricky expressed great delight in your degree of community connection, community outreach, and the services that you provide to the patient population. When I look at the map, I see multitudes of other areas of the country that have the same patterns of population, poverty, problems. How does the translational aspects of your research going into Baltimore, to Salinas Valley, to New York City get translated to a much larger population?
Yeah, so it's an awesome question. I think from the asthma perspective first, from some asthma perspective, there isn't one single thing you could take away that would make all asthma get better or go away. And we recognize very clearly it's a multifactorial illness with a multifactorial approach to solving it being the best. And that means that you need to tackle all of the allergens that are in somebody's environment and all the pollutants at once to get the best effect. The allergens and pollutants vary across the country. So there are, if you look at dust mites, for example, for some reason we don't have many in Baltimore. We've looked over and over and over again. Dust mites are a big problem down south, so down in Louisiana. I think there's a lot of dust mites in Seattle from what I've seen too. Mice and cockroaches vary as well, right? Isn't that right? Yeah. And so mice and cockroaches vary. So I think a big point is that none of this really should lead to a one-size-fits-all solution. What it should always lead to is a customized solution based on what the actual components are. But I think some of it's generalizable, right? If we can show that where there are mice, if you can get rid of mice and the health gets better, then you can do that, theoretically anywhere. But if you don't have mice, then you wouldn't work on them. You'd work on something else.
One of the things we also do between HHS and EPA, specifically with ATSDR, is we have these pediatric environmental health specialty units. Those physicians and healthcare providers in those locations are well aware of the work that's done in these research centers. And I think we have 12 of them now. There's 10, how many? Well, there's 10 in the U.S., and then there's a couple, one or two in Canada and one in Mexico. But those centers are a place where we can spread out the information and translate the information. And it's applied, as Greg said, you got to focus on what's happening where you live, and those pediatric environmental health specialty units can take this research and apply it where it is. Linda?
I think the question, though, Jerry, that you were asking actually has to do with how broadly do these findings get communicated nationally or internationally. And the answer is these children's centers are just one aspect of what we do. We have many other centers that are communicating the work that's learned here. So our environmental core centers, our breast cancer and the environment centers, our training programs. So it's spread more widely, and also the communication that we try to get out through many different ways. It's not limited to just the children's centers communicating and working with those individual communities. Obviously, the one-to-one relationship, as Brenda talked about, with her really strong feelings with the Tramacos community and stuff like that, you have that kind of really tight. But the understandings are sent out much more broadly.
Brenda? I have 2 points about that. First, for some reason, the press really love the work that we do. So our work doesn't just get disseminated in the Salinas Valley. In fact, it gets disseminated all over the world. We get a lot of press coverage. In fact, our press officer for the university says, I feel like I spend too much time talking to you. So we're really always in the press. Whether it's national news, Good Morning America, or New York Times, we're in the press. Our results are generalizable. The other second point is there are 4 centers that look at, as an example, the relationship of in utero exposure to organophosphates. And 2 were in New York, and 1 was in Cincinnati, and 1 was in California. By the fact that we have these children's centers all over the country, we can see if our results are truly generalizable, and whether our results really are dependent on the population or really dependent on the chemicals.
And it's not by accident that we're doing rural and urban communities. It's on purpose because we want to see what's affecting our kids everywhere. And then if it's generalizable across that spectrum, we do it. If it's focused, we focus. But that's why these centers are so important. That's why we want to celebrate these 15 years. As Linda said, we continue to learn a lot more. We're not doing the same things we did 15 years ago. And the big key, I think, with these centers is the translation to the community and the translation to the larger to our country, as well as to others around the world. And we have learned a lot. And until we had these centers, we didn't really have a center of focus on children's environmental health, a center of research and translation and community action. And I think that's the power of these centers, and that we continue to learn and continue to have healthier kids. And the truth of the matter is, healthier kids who get to go to school, learn more, become healthier adults who can be more productive members of our society and more successful for themselves and their families and our country. And that's what we think this is all about. And I don't know, Linda, if you want to say anything, or anyone has a final word, but I just want to thank all of you for coming. I want to thank our co-sponsors for the lovely refreshments. I want to say how grateful I am to NIEHS for this great partnership that we've had over the years. I want to introduce Dr. Jim Johnson of EPA, who is our lead for these children's environmental health research centers. Please, if you have questions or you want to know more about it, Dr. Johnson is our man.
And then I'd like to introduce Kim. Where's Kim Gray? They had to catch the bus. All right, they were lucky. They made it early.
Yeah, we can get the four of us together. And I also want to specifically thank the EPA and the NIEHS folks for making this happen over many years, and the researchers who have dedicated really their lives and their careers to understanding more about our kids so that we can all make a difference. And I want to thank those of you from Congress who helped us do this through hearings, through dedication and commitment to this subject matter, through caring about the kids themselves, whether they're, the kids in our agricultural communities, the kids in our cities, wherever they are, they're our kids, and you have all made this possible. And I want to thank you all very much. So a hand for everybody.